Cardiac potential is the main character of this chapter, but the mastermind working behind the scene is the resting membrane potential. Let's see how. Remember, cardiac potential is just a response of the cardiac cells. As we know, when some stimulus arrives here, cardiac cells give some response. So, cardiac potential is just an electrical response of the cardiac cells. And this response depends on the properties of the cardiac cells. We have discussed about few properties like the excitability, chronotropy, dromotropy. Now, these properties are not constant. These properties depend on one important variable, that is the resting membrane potential. These properties depend on the resting membrane potential. Further, some conditions like the ischemic heart disease, hyperkalemia affects the resting membrane potential, and this will further cause the cardiac arrhythmias. So, lot of things are revolving around the resting membrane potential. Before talking about the dynamics of cardiac potential, let us focus on some terminologies. First of all, we will take cardiac potential. This is a fast cardiac potential. It has got various phases: phase 0, phase 1, phase 2, phase 3, and phase 4. So, this is the duration of phase 0, this is the duration of phase 1, this is the duration of phase 2, this is the duration of phase 3, and this is the duration of phase 4. So, these are the phases. We already covered the name of these phases in chapter 4a. Now, we will talk about some terms. Cardiac cycle duration. So, we know cardiac cycle duration is from phase 0 to the end of phase 4. Okay, so it is from phase 0 starting to the phase 4 end. So, this time interval is the cardiac cycle duration. Another thing is this blue arrow. This is the cardiac potential duration, or we can say action potential duration. We usually write like this. So, this is from the starting of the phase 0 to the end of phase 3. This is starting of the phase 0 to the end of phase 3. So, this is the action potential duration. Next term is the effective refractory period as shown by the green arrow. This is effective refractory period. This corresponds to the absolute refractory period, and this is the time interval between the phase 0 to the effective recovery of the inactivation channels of sodium so that they can fire again in the phase 3. So, this is the effective refractory period from phase 0 to the somewhere between the phase 3, means here recovery of sodium channels. So, this is the effective refractory period. Further, we can say, as we know, this is some point there is threshold above which when potential goes, it can form a spike. This is the threshold. Now, we will cover one by one different phases of the cardiac potential. Now, talking about the phase 0 of the fast cardiac potential. As you know, this is the phase 0. So, the currents responsible for this phase are sodium current and calcium currents. But sodium currents are predominantly responsible because of the fast dynamics, because they open fast. Now we will see how sodium current governs the phase 0. So once these fibers, atrial fiber, Purkinje fiber or ventricular fiber get stimulated by some means, so what will happen? The membrane potential will depolarize a bit, means it will get less negative. So we can say this minus 90 millivolt potential will comes at, let's say, minus 70 millivolt. So stimulus will cause depolarization of the potential. Let's say Vm becomes minus 70 millivolt. So what will happen? So once it becomes minus 70 millivolt, so it will cause more opening of the activation gates of the sodium channel. So activation gates open. So when more activation gates open, then what will happen? The permeability of the sodium increases. So this will lead to increase permeability of the sodium ions. So when permeability increase, we have learned the sodium current will also increase, and we have learned sodium current flows inside. So sodium current flows inside, so it will increase the membrane potential. So it will again increase the membrane potential to some minus 60, minus 50 value. So it will come here minus, let's say minus 60. So what will happen at minus 60? More action, more activation gates will open again. So this is nothing but a vicious cycle, and we will call it positive feedback. Positive feedback. So because of this positive feedback, the membrane potential shoots to a very high level in a short time. So we can call it a spike. So this is how sodium will cause the phase 0. As far as calcium current is concerned, calcium current is also responsible for it, but as we know, calcium channels are bit slow channels. So their effect will come but after a delay. Now I want to emphasize the importance of resting membrane potential. How the change in the resting membrane potential leads to a different dynamics of the phase 0. Let's take an example of ischemia. As we have learned in chapter 4b, ischemia causes the membrane resting membrane potential to a higher value or less negative value. So thus resting membrane potential will depolarize a bit. So in case of fast muscle fibers, if resting membrane potential is at minus 90 millivolt, let's say because of ischemia it comes at minus 60 millivolt. Now what is going to happen? For phase 0, sodium current should be present. So as we know, sodium current, always remember, is a multiplication of its permeability multiplied by its electrochemical gradient. Now, this resting membrane potential is also shown here. But more important is this permeability. As we have learned, permeability is governed by channels, and the channels here are the voltage gated channels. So their gating mechanism is dependent on the voltage of membrane potential. So these channels are itself a function of voltage or membrane potential, and they are also depend on time. We have talked about the voltage dependence and time dependence of these channels in chapter 4b. So permeability depends on the membrane potential. So now at this potential, though it seems this potential is more nearer to the threshold, so one can interpret that uh, excitability may increase. But along with this, also remember, when potential comes to at this level, so what is going to happen? If this is the activation kinetics, this is the activation gates, and these are the inactivation gates. So once potentials comes at higher values, like here, so most of the inactivation gates got closed, means sodium channels are not available. So their permeability decreases. So we can say at minus 60 millivolt, permeability of sodium ions decreases. So when permeability decreases, the current also decreases. Sodium current also decreases. This leads to decrease in the sodium current. And when sodium current also decreases, the Vm will rise at a slow rate. So we can see the slope of the phase 0 is decreased here. So this is how we can have implications of the resting membrane potential. So one effect we have seen here. So what we can interpret, once the resting membrane potential comes at a less negative value, the excitability of the cardiac muscle cells decreases. So it will decrease the excitability. Decrease excitability. Another thing that we have discussed in chapter 4a about the dromotropy. I told the slope of the phase 0 governs the conduction velocity. So here the phase of the slope 0 goes decreases. So conduction velocity also decreases. So this is the another property, dromotropy. This leads to a decrease in the conduction velocity. Now we focus on the dynamics of the phase 1 of fast cardiac potential. As we know, as the potential goes high, most of the inactivation gates of the sodium channels get closed. So this will lead to decrease in the sodium current. So inactivation gates decides the amplitude of the cardiac potential. Another current that is important here is the potassium current of transient outward rectifier variety. And channels responsible are the voltage gated sodium channels. This leads to a rapid repolarization phase of the cardiac potential. Now talking about phase 2 of the fast cardiac potential. In this phase, there is no significant change in the voltage. So it means the net current during this phase is nearly zero. So in this phase, there are two types of current. One is the inward current, that is predominantly constituted by the calcium ions, but a minor component is of sodium ions. And outward current is due to the potassium ions. Now, as we know, the channels responsible for the calcium currents are L-type calcium channels. As we have studied in chapter 4c, that these channels are slow channels. So it takes time to open. So when stimulus came here, but they are taking time to open. So now the calcium current is on peak. But sodium current, because of the closing of the inactivation channels, got less. Now talking about the outward current, that is the potassium current. Potassium current here is basically the delayed outward rectifier current. Even this current is also of two varieties. One, rapid component, and another is the slow component. So as we have already know, these are again slow channels, very slow channels. So they are taking time to open. So potassium current is gradually increasing. During this phase, potassium current is about same as the calcium current. So this is a phase 0. But later on, this potassium current will continue and leads to the phase 3 of the cardiac potential. Now focus on one application of these concepts. If let's say this potassium current decreases, so what will happen? If potassium current decreases, the membrane potential will not come down or it will not repolarize. So it will lead to the increase in the action potential duration. So when IK is decreased, this will lead to increase in the action potential duration. That will be reflected in the ECG. Now focusing on the phase 3, that is the repolarization phase. In this phase, there is repolarization happening, means membrane voltage is coming to the downward side after depolarization. So the current responsible for this phase is the potassium current, and again we have see in the last slide, this current is constituted by two varieties, that is rapid and slow component of the delayed outward rectifier current. In phase 4, as we can see, again the voltage is not changing. So the net current during this phase is also 0. Now we will talk about the dynamics of the slow cardiac action potential. As we know, slow cardiac potentials have three phases: phase 0, phase 3 and phase 4. Phase 1 and 2 are not present in the slow cardiac potential. Another thing we have to focus is on the maximum diastolic potential, means it is about minus 60 millivolt. So this potential works around minus 60 in comparison to the fast cardiac potential, whose resting unit potential is minus 90 millivolt. And the reason behind minus 60 millivolt is that the potassium permeability of these cells is less. So that's why its resting unit potential or its maximum diastolic potential is quite far from the nurse potential of the potassium ions. Now talking about the phase 0. Phase 0 is governed by the calcium current, and we have discussed the channels responsible for them. These are the L-type calcium channels. Now as we know, these channels have a slow kinetics, means they take time for activation and inactivation also. So because of this reason, the change in the potential is not as the fast cardiac potential. So we can say slope of phase 0 is not as that steep as the fast cardiac action potential. And we know, so slope of phase 0 is not steep here. And we have discussed the relationship of the phase slope of phase 0 with the conduction velocity. When this phase have a steep phase leads to fast conduction velocity, but in this case it is not required. As we know, in AV nodes we need a delay. We want to delay the conduction. Okay, so this is appropriately suits to the role of the AV nodes. Now we will talk about the phase 3. Phase 3 is governed by the potassium currents, and the current is the delayed outward rectifier. Lastly, we will talk about the phase 4 of the slow cardiac potential. And this is the phase because of which property of autorhythmicity is present in the slow cardiac potentials. Potential in this region is known as pacemaker potential or diastolic potential, and the minimum potential here is known as the maximum diastolic potential. The currents responsible for these phases are, we can divide it into inward currents and outward currents. Inward current are the funny currents predominantly, and a bit of calcium current that are governed by T-type channels. And outward current is the potassium current governed by G protein inward rectifying potassium channel. So we have discussed about the funny channels in chapter 4C. Funny channels have a special property, and that special property is their gates start open when the potential becomes more and more negative. So the same thing happens here. As the potential goes towards the negative sides, the funny channel starts to open, and because of the opening the current enters these cells and it will depolarize the cell, and again it will take the potential to the threshold, and a new slow cardiac action potential fires. In this way, the property of autorhythmicity is attributed to these cells, SA nodal cells and the AV nodal cells. I hope you will like the lecture. Thank you. Thanks for watching.